Good evening, good evening. Uh, December 13th, 2021. As you know, people say 13 is a bad number. Uh, and I've tested that number over certain incidents, including personal incidents. So it's not a blessed number for America, but it is a number. So I want to take advantage to make good from the bad. Today I went to some sites, visiting 1,000 guys, a pool of 1,000 guys. Uh, most of them from my origin, people I've related with. We've worked together, making cash, making money, and I found like few of them have departed from us, and from me actually, people I were close to, people I have played checkers with, people I had good rapport with, they departed. I didn't know. So we know coronary artery disease, CAD, is the leading cause of death in America, and I would say over the world. And graduated a long time ago as a physician, but after in different places, New York, Manhattan, which is a place that I like, seeing they call it the building of freedom or liberty. I like that. Not that I like the building, but the view is a beautiful place. But I like being in Manhattan, close to the Reserve Bank. It's a nice place to be, where I've taught for a little while. As I said, passed some of the U.S. boards. I did 4 years of residency. People say I'm gifted or I was gifted. But even when I was teaching in Manhattan on Sundays, I was able to operate a few wonders. If I didn't go to church, the Spirit follows me, or He was there, allow me to do things. But my presentation, I call it EKG Diamond. As a medical student, I know my strengths and weaknesses. Passing the boards, I remember strengths and weaknesses. And even you have nurses, PA, physician assistant in America or elsewhere, globally. Some physicians who may have learned those skills initially in med school, but never, I would not say internalized, but never spent much time to master them, to master those skills. And it's a weakness, it's a secret in medicine. Because, it's about your heart. If you know the way your heart functions, that improve your circulation mentally, decreasing your stress. If you had to read a 12 lead, or you're working on telemetry, med surge, you're in the emergency room, operating room, operating room, or anywhere else, you'll be dealing with the cardiac monitor. You'll see some leads, and as a clinician, regardless of your status and the medical ranking, they would expect you at least to master those basics. So I'm doing this for different guys, kids that I know. Some of them are my godchildren, and now becoming physician. Maybe someday they'll be working in America. They may try to make it here or elsewhere in Europe or in Canada, part of America as well, but somehow, so to speak. So it is. So, or being in the native country where they will be practicing. So once and for all, this is a secret. Most clinicians won't tell you about it. They say if you don't know it, try to know it or figure it out yourself. It's a secret in the field. People won't tell you about it. There's pride when somebody masters a bit of the EKG. We know initially created by Wilhelm, apparently some German physicist, which is the EKG, electrocardiographic reading, telling the electricity within the heart what is taking place. As you see on YouTube, there are many of those slides, but I would be having 4 or 5 series. I call them EKG the Diamond. So I will take you from the beginning, from working you through to the next 4 or 5 courses. I call them EKG the Diamond. And for my guys, that will prepare you if you have to take the medical board exam, Canadian board exams, or you go to Europe, France, Spain, Italy, or elsewhere. So those will save you a good 15 to 20 points, or 20 questions, 15 questions. As a nursing student trying to pass your exam or practice, again, that will free your mind of certain, you don't have to be practicing, having that weakness which you never get touched, to review. You may know the basics, but you forget them. You never go in depth. So we won't keep it long. But that's the intention. If you have a chance to listen to those, that will help you. So I know everybody has a limited time to go YouTube or to go listening to somebody talking EKG, but it's a secret. It's a secret in the field. And my intention as a physician, a spiritual entity, I give myself different titles, is to penetrate you, your conscience, and allow you to grasp the idea. So what is my background? I've taught anatomy and physiology, microbiology for 5 years in a community college. I passed the boards, worked in a transplant as a coordinator for a little while, and then get into a hospital. Did 4 years of residency, a little bit more than 4 years, quote unquote. I've seen many patients. Most of them was either a few times on the medical floor, what we call psychosomatic medicine. You go on the floor, you see medical patients with psychiatric condition in the emergency room, a million crisis unit. So I've seen all those psychiatric comorbidities or psychiatric disturbances, all of them. I've seen them. So anyway, so my point, I'm test-based initial skills, and we'll take it from there. So we've talked about the heart. Initially, we know the heart. We have 4 chambers. Where is your heart located? A nurse, a medical student, obviously they know that already. So above the diaphragm, in the thoracic cage, thoracic cavity, on the left side, from, say, to some extent, you go all the way to fifth intercostal space when we're talking about some of the components of that. So your heart is on that side, right? Even though you see the right, this is the left. It's on most of the time. That's what is called dextrocardia. It is possible for a very small percentage to have it located on the other side, on the right, but usually it's on the left side. And as you know, contractions, respirations, those are unconscious mechanism. You're not aware you are breathing unless you have a respiratory condition, COVID or something else. A cold, a bad cold almost killed me the other day. Or if you have chest pain, now you are aware how important is your heart and so on, circulation. So we're saying, I'm gonna bring my camera close. The heart in itself, I'll put the lungs right here. The heart has 4 chambers. There's a muscle that divides the heart into the right side and the left side. It's called a septum. Then we have the 2 valves. Those valves, this is called the tricuspid valve. This is the mitral valve, right? So the tricuspid valve divides the right atrium from the right ventricle. And then we have the left atrium, and we have left ventricle. There's another valve here called the mitrals. So I know why I'm touching those basics as an introduction to the class, right? To what I'm trying to achieve here. So 4 chambers, right atrium, left atrium, right ventricle, left ventricle. Not sure how much you can see. Let's move it closer again. put the lung so that you know that's the rib cage. And here, that'll be the muscle, diaphragm, and so on. Takes a few things to get back up. Trying to offer our help here. All right. So if you don't understand something, you cannot explain it. It's a basic principle, unless you're making up things. So here, I'm not going over the circulation for now, since I'm talking about the EKG or ECG, which is electrocardiographic. Electrocardiographic reading, which tell you about the conduction system within the heart itself, the conduction system. So here, in the territory of the superior vena cava, right behind the superior vena cava, there's a node here, part of the conduction system, right? This is where it starts. This is called the SA node. The SA node stands for sinoatrial node. Okay? Sinoatrial node, the SA node. The SA node will send fibers to another node right here called the AV junction or AV node. Internodal fibers. And we'll send fibers also to the left atrium, several fibers. So really through the SA node, there will be stimulation of both atria, the right atrium and left atrium. Internodal fibers. However, interestingly, both atria somewhat contracts at the same time. Interestingly, for the EKG, the SA node will give you what is called the P wave. The first wave you will be looking at is called the P wave, right? So we'll do it better next time. Doing our best right now. I need to honor these guys, and I need to do something. The P wave stands for, we said, contractions. Contraction, there's a term for it, a physiological term called depolarization or systole of the atria. Contraction of the atria is called depolarization. This is when both atria are contracting at the same time. They give you what we call the P wave. So initially that's what we have in a basic EKG. If we're dealing with the lead 2, the one you will most commonly see on a cardiac monitor. So we have the P wave, which stands for contraction of both atria or atrial depolarization. So after the P wave, we have another one coming up called the QRS complex. Okay? The QRS complex. The QRS complex, which stands for ventricular depolarization. Both ventricles will contract. However, we need to put it on these slides right here within the heart. So now we start with SA node that gives us the P wave, atrial depolarization, give us the internodal fibers within the right atrium, then send those fibers to the left atrium. So SA node, AV node. from the AV node or AV junction, we're going to have what is called the bundle of His. Going down over the interventricular septum, we have the bundle of His. So the bundle of His will give you other branches. It's going to give you a right bundle branch. Going to give you a right bundle branch and a left bundle branch. However, the left bundle branch will split to give you two other branches. The left bundle branch will give you an anterior fascicle, okay, and a posterior fascicle. So right bundle branch and you have left bundle branch. The left bundle branch, divided into, in most situations, to give you the anterior and posterior fascicle. And then from the right bundle branch or left bundle branch, those branches will give fibers downwards throughout the musculature of the ventricles. Those fibers are called Purkinje fibers. How do we put that, interpolate that, if that's a good word to use in the EKG? We put the P wave on top, right here, the beginning of P wave. We say this is called atrial depolarization, contraction of the atria, of both atria, P wave. QRS complex, we say that's the contractions of the ventricles. In some situation, you would say the left ventricle will contract first, then the right ventricle, but really, in practice, I want you to understand that both ventricles, the systole happens about simultaneously, we would say, for the sake of discussion. Both atria, they perform contraction, pushing the blood downwards, crossing the tricuspid from the right, and the mitral from the left, going into the ventricles, and then ventricle will contract to push the blood downward towards the aorta on the left ventricle and the pulmonary artery on the right ventricles. And obviously, the aorta will send the blood throughout the body, supply oxygen, and at the base of the aorta, this is where the carotid arteries will take their origin, right here. Right and left carotid, and then what I'm talking carotid, right and left coronary arteries, sorry. Right and left coronary arteries will give branches to supply oxygen to the myocardium of the heart. All right, so we have P wave. SA node give you the P wave. QRS complex stands for ventricular depolarization, contraction of the ventricles. And then we're going to have what is called the T wave. After the S, you have the T wave. T wave is the repolarization of the ventricles. That means, repolarization means the resting mode when the ventricle is in the filling, is in filling mode, diastole. So physiologically, contractions, SNL will give, is activated during contraction of the atria. You have the P wave for the atrial contraction or systole or depolarization. That's the best word to use, depolarization. QRS complex stands for ventricular depolarization, the QRS complex, ventricular depolarization. And then the T wave is relaxation phase, which is the repolarization of the ventricles. When the ventricles are in filling mode, they are receiving blood prior to being contracted. So P wave, SA node, this is very important. The SA node beats 60 to 100. This is the pacemaker of the heart. When you say the pacemaker, SA node, this is where everything starts, is the pacemaker. Pacemaker of the heart beats 60 to 100 beats per minute. Beats per minute. So in an adult and children, infant, that varies. It's faster, much faster. It could be up to 180, it could be normal, depends on the age. And over time, it will slow down. By adolescents, the heart rate will be about adult age. But for adolescent, like 12 and beyond, 60 to 100 is the normal. That's the work of the SA node, sinoatrial node, which we call the pacemaker. is the P wave. So when you're reading an EKG, if you see P wave, we say it's a sinus rhythm. If you don't see the P wave, it's not a sinus rhythm. The QRS complex, ventricular depolarization or contractions. And the T wave, we say is ventricular repolarization. Or the ventricle is in the filling mode, sorry. So what about when the atria is in relaxation, is receiving blood from the superior and inferior vena cava and the right atrium? What happens? So this is hidden behind the QRS. We only see contraction of the atria, P wave, contraction of the ventricles, systole. We call that, both are depolarization. Atrial depolarization give you P wave or SL node. Ventricular depolarization or contraction give you the QRS complex. And the T wave stands for ventricular repolarization. And briefly, we need to mention for my guys what depolarization stands for. This is movement of iron and cation, especially sodium, potassium, calcium, when they're moving in and out of the cells. So when you read your book, you see that term depolarization. When sodium moving in, you remember the extracellular concentration of sodium. When calcium is moving in, the inside become more positive, and that evokes some contractions, action potential. However, that's during contraction, sodium and calcium move in. So potassium quickly get out of the cells to the sodium potassium channels and so on, the calcium channel. So now, when doing repolarization, relaxation phase, mainly in the ventricles, that we don't want to focus on. So potassium now get into the cells and chloride, and then quickly, even though potassium is positive really, but more sodium and calcium get out, so the inside become less positive. That provokes some relaxation phase, and that gives you the T wave when potassium is increased during relaxation phase within the cell. So depolarization is movement of sodium calcium inside, making inside more positive. For the atria, gives you the P wave. For the QRS, also depolarization, QRS complex, and the T wave for repolarization. Now, there's what is called from the P wave and basic EKG. When I teach that's what we call the PRI, the PR interval. The PR interval is from the beginning of the P up to the R, PR interval. Normally, in a graded paper, on the EKG, those graded paper, they have you have two solid lines, and you have 5 small boxes on the inside. For 5, each small box is 0.04 seconds. So 3 is 0.04, 2 is 0.08, 3 is 0.12, 5 is 0.20. So when you look at that two solid lines in an EKG, so the PR interval is 3 to 5 boxes. The PRI, the PR interval, we say is 3 to 5 boxes. When you're reading a 12 lead and so on, if you see the PR, it should be 3 to 5 boxes. If it is longer than that, we say the PR interval is prolonged, and it could be a type of block we call first degree AV block. If it is continuously prolonged and so on, it's not that worrisome, but you need to know on basic EKG. The QRS complex, normally an adult, is 0.06, which is 1.5 box, up to 0.12, but some textbook would say 0.11. 0.06 to 0.11, 0.12. That's the QRS for the ventricular depolarization or contractions. So it could be wide, depending on some pathology later on, and the other classes will explain that the QRS could be wide, but you expect it to be 0.06 to 0.11, 0.12 in adult. Because in kids that would be 0.09 and so on. Now, so P, QRS, and T wave. We say the SA node, the pacemaker, beats 60 to 100. Normally, in a rhythm where you see the P wave, if it is less than 60, you see P wave is less than 60, but then you need to know how to calculate the rate. There are at least three formulas to do so. In a 6-second strip, you need to count the number of R wave. Those usually is upper deflection. In the QRS complex, you measure the number of R wave and you multiply that by 10 because you have 60 seconds, which is 1 minute. If you know what you have, how many R wave you have in a 6 seconds, just multiply it by 10, you get the heart rate. That's one. And there's another one, you get the 300, 150, 100, 75, 60, 50, 40, but that's something else. And then where you can, also there's another one where you calculate, you get 300, you divide it by the number of R waves that you have to give you an approximation. But learn the basics now. For now, the most commonly used is calculate the number in a 6-second strip, the number of R waves, the upper deflection one most of the time, and then you multiply it by 10, it gives you the heart rate. Okay, P, sinus rhythm. P, it's atrial depolarization or contractions. QRS complex, ventricular depolarization or contractions. And T wave is ventricular repolarization or relaxation phase when the ventricle is in filling mode, is receiving blood. It gives you the T wave. So when we're talking about pathology, then we can go over those details. So the QRS complex, which says it should be 1.5 bucks, 0.06 up to 0.12, up to 3 boxes, right? I would say again, some literature may say even 0.4 to 0.11, but the wisdom is that most commonly we take 0.06 or 0.04 up to 0.12, right? About one to 3 boxes millisecond. All right. So normally the ST segment, you want it to be horizontal, kind of. We call that isoelectric. If the ST segment is elevated beyond 1 or 2 millimeters, depending if we talk about precordial leads, which is chest leads or limb leads, it could be greater than 1 millimeter or 2 millimeters. That would be significant. But that would be in a 12 video. When we talk about ST segment elevation, people have conditions such as ischemia or some type of infections and so on. ST elevation MI, but we need to get there. We need to start with basic EKG first. So PQRS and T-wave, that's the introduction. Now, SNO is the pacemaker, 60 to 100, but if the SNO fails to contract, fail to depolarize, then the next one that will take over will be the AV node or the AV junction or the AV node. So the AV junction or AV node is slower, it's 40 to 60 beats per minute. So there are some rhythms where you don't see P wave, they start about the level of the AV junction. So when we get there, we'll talk about the escape rhythm, junctional escape rhythm, and so on. Junctional accelerated junctional escape rhythm, and so on. When you don't see the P wave, it's about the AV area. Now, and then below the AV junctions, Purkinje fibers, Purkinje fibers is 20 to 40. They beat 20 to 40 over here. So if the AV junction fails to depolarize, then the Purkinje fibers will be the one being depolarized. And when they become the pacemaker, they beat 20 to 40. That will be a very slow heart rhythm. So either we're talking about bundle bunch block, that will be a very slow rhythm, or the pathology where you have second degree or third degree V block and so on, complete heart block. We'll get there. So today I want you to get the concept. There's something else to mention. The autonomic nervous system does play a role, to the chemicals, the neurotransmitters that are being released, and some fibers coming from the brain. So parasympathetic, the vagus nerve, over the heart, it will slow down the heart. And when epinephrine or norepinephrines are released, they will stimulate the contraction. And also some other electrolytes that can influence. Too much potassium can make it faster. Too much potassium can slow it down. Hyperkalemia slow down the heart, and then hypercalcemia may stimulate it and so on. All right. So I want you to get the concept of SA node, sinoatrial node, give you the sinus rhythm, P wave. It's for the atrial contraction, but when you calculating the QRS complex, is ventricular contraction, both ventricles. It's biventricular contractions, QRS complex, and we talk about the measure of the QRS complex, and the T wave stands for ventricular repolarization when the ventricles is repolarizing. So I'm gonna bring you closer. SA node, AV node, okay, Purkinje fibers in the ventricles. Okay, SA node, superior posterior, somewhere behind the superior vena cava, is the pacemaker of the heart, beat 60 to 100. AV node, about 40 to 60. And then we have Purkinje fibers, 20 to 40. Okay, so those are the three components of the conductive system of the heart. So P, QRS, and T wave. And a 6-second strip, this should be repeated. So after every T wave, you should have another P wave, another QRS, and after every P wave is a QRS and T wave. So there's more to talk about, but for now, it's the introduction. Stay blessed. We'll keep going. Ciao.